Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello everyone, my name is Bernadette Sabados and I'm the lead of the Superficial Bladder Cancer Service at the University College London Hospital in London, United Kingdom. Welcome to this program titled Immunotherapy for Non-Muscle-Invasive Bladder Cancer, Expert Takeaways from the Latest Updates. Joining me today are Maria De Santis, Professor of Translational Geo-Oncology in the Department of Urology at the Charité Universität Medizin Berlin in Germany, and Neil Shore, Director of the South Carolina's Carolina Urologic Research Center in South Carolina, USA. Welcome to both of you. In this activity, we are going to briefly introduce the current therapies for high-risk non-muscle invasive bladder cancer and the rationale for using immunotherapy in these patients. We will then describe the latest key data from immunotherapy and BCG combinations in high-risk non-muscle invasive bladder cancer patients, and most importantly, discuss the possible clinical implications from these data sets. So first of all, let's go through the current treatment options for high-risk NMIBC. Now, this is my first question to you, Maria. How would you actually define the high-risk NMIBC patient population?
Well, thank you, Bernadette. Well, we have different guidelines, and with them come definitions, and this includes EAU and AOA and other definitions. I would like to explain maybe the EAU definition, which we are using in Europe and also in Germany. And here we have high-risk NMIBC definitions. And the EAU guideline is very detailed, but we are on the safe side when we stick to these explanations and to the definition. So all T1 high grade or grade 3 without CIS are defined as high risk NMIBC, except those included in the very high risk group. Also, all patients with carcinoma in situ, except those included in the very high risk group. We also have additional clinical risk factors like age above 70, multiple papillary tumors, and tumor diameter of 3 centimeters and above. So TA low grade or T1 grade 1 with CIS and all 3 risk factors would also be high risk. And this is also true for TA high grade, grade 3, or T1 low grade with no CIS and 2 risk factors, and T1 grade 2 with no CIS and 1 or more risk factors. So you see, this is quite complicated, and I always recommend to have these guidelines at hand so we don't overlook something.
Thank you so much, Maria. I agree that this does seem a little bit daunting and complex. So I always have the online version of the EU guidelines open in my browser. Neil, are there any differences with regards to this definition in the US? Maybe, hopefully, a little bit more easier.
Yeah, there's differences, and I agree with Maria. And I agree with you, Bernadette. And thanks so much for moderating the program today. It can be confusing, and it's not just only in the high risk and the very high risk. And I even think we have some nuanced differences as to how we describe intermediate risk. I think if you look at International Bladder Cancer Consortium, the IBCG, the National Comprehensive Cancer Network, NCCN, as well as the AUA Astro consensus, there are some nuanced differences. And I, like you, I have to go back and look at it But I think for the purposes of our discussion today, really focusing on the CIS, the T1, the lamina propria slash basement membrane invasion, and the multiple high grade papillary larger lesions is really everyone pretty much says these are patients who are at high risk.
Super. Thank you so much. That made it a little bit easier. So, in terms of therapies that are currently recommended and approved, what are the differences between Europe and US? Maria, do you want to kick us off with what's available in Europe?
Sure. So the major difference, I think, is with BCG unresponsive or BCG intolerant, where we don't have a lot of options in Europe. But in the first place, everything starts with a well done TURBT, and if it is high risk or yeah, high risk or very high risk, we usually start with full dose intravesical BCG. However, in both circumstances, high risk and very high risk, a radical cystectomy is also discussed with the patient as a valuable option. Um, if the patient is very high risk or BCG unresponsive, usually radical cystectomy in Europe is recommended in the first place, and BCG in the very high risk is a second choice. Um, we also are trying to put patients on clinical trials as we have a kind of lack of options in the BCG unresponsive population. Also, and this is good news, we have an CHMP positive opinion for patients with carcinoma in situ that are unresponsive to BCG. And this is nogapendekin alpha invakisept plus BCG in this situation, but we don't have the other options that are available in the US.
Super. Thank you. And Nia?
Yeah, I agree with Maria. Full dose intravesical BCG for our high risk patients who are BCG naive. That's been the standard of care ever since Pablo Morales, figured that out a long time ago, kind of serendipitously picking those 6 vials and the induction of 6 weeks. And many of our patients, I think worldwide, will get some form of post TURBT chemotherapy, various iterations, gemcitabine, others, to try and cut down on recurrence. But cystectomy, of course, is an option. But I think as we've gone more and more, at least in my career, is most patients would rather do almost anything to maintain their bladders. There are a few exceptions, but it's a big operation, and when it's well done, we've got some nice data that just recently came out that patients actually do very well, but it's still really one of the most complicated, biggest procedures we do, and it's pretty life altering. In the US, we have this really kind of embarrassment of riches on the unresponsive side. In addition to chemotherapeutics, mostly in the US, it's a combination of gemcitabine with docetaxel, but even though there's no phase 3 data on that, we have nadofaragene faradenovec, which is an intravesical based therapy. Also, the nogapendekin. I'm not going to say the whole thing. Maria said it so well. I can never repeat that. We even have pembrolizumab, and then there's even, believe it or not, there's another one still on the books called valrubicin. But I think the take home for this, for me, this question is, how do we keep patients from developing unresponsive disease? And how do we prevent this whole cascade of highly expensive and not always available therapeutics where they're really only in the US and not everywhere in the US for that matter? And how do we keep patients avoiding that inflection point of going from sensitive to BCG to unresponsive to BCG, and arguably avoiding the need for a cystectomy?
I absolutely agree. And I think one of the cornerstones of the management of these patients is really to do a very, very high quality TRBT. But beyond that, what do you think are the key challenges and unmet needs for managing high risk non muscle invasive bladder cancer?
I'm no urologist, but of course, and the perfect TURBT done by an expert or supervised by an expert, I think is very important. However, for the patient, a recurrence or progression, or let's say starting with a bit recurrent, um, is always a challenge because it is another intervention. The patient will have more TURBTs with every recurrence, not to speak about progression, which implies more anesthesia, hospital stay, at least in Europe. It is not done as an outpatient. And afterwards, if it is high risk recurrence, more instillations, more therapies, and lengthier, also expensive therapies. Um, the functioning of the bladder might worsen with more TURBTs and more installations in the long run. The patient actually would, of course, be scared and also would be scared about the outcome of the recurrences. And the patient would have more symptoms with the interventions and like dysuria, urinary tract infections, or hematuria. And finally, the patients usually don't like to lose the bladder, but ultimately they might, I have to go down the road of radical cystectomy. Uh, and also have the risk of muscle-invasive bladder cancer metastasis or death, which is fortunately rare, but there is a small risk left. So this is the broad spectrum of challenges and the unmet needs and difficulties with managing high risk NMIBC.
So broadly, extremely multifactorial, but I guess we are kind of coming back to the standard of care treatment, which is the intravesical BCG therapy. Neil, I was wondering, could you tell us a bit about potential limitations of the BCG therapy?
There's a lot of different manufacturers of BCG. Um, and so there can be variations in the quality of the strains. That's been an ongoing debate depending upon where in the world you are, where you receive your BCG, who's manufacturing it. So some issue on quality control. I think it's important that, especially in our high risk patients, the real issues are these 2 points that Maria brought out is not only recurrence, but progression. The recurrence hassle phenomenon, we see a lot more in our intermediate risk patients. And so when you get into this cycle that Maria described of repetitive TURBTs, the attendant removal from your work or home, the anesthetic, the risk of complications, bleeding, perforation, catheterizations, infections, etc. And we have so many of our patients who have had not just a few, but 10, 15, 20 of these episodes. And as they get older, just as the aging bladder deteriorates, it deteriorates potentially more dramatically with all these bladder biopsies and anesthetics and complications. So the implication, given that high risk has about a 40% evolution to recurrence and progression, it has and not only a really significant clinical implication for the individual patient, but arguably to the healthcare systems. And I think these health economic understandings and modeling is really important. Other things too is, and we've all experienced this, we do our trials, and we're going to get to it in a minute, the importance of rigor to a protocol. So the right amount of induction, getting the fidelity or loyalty to the maintenance schedule. But a lot of times, there's a challenge with these 1, 2, let alone 3 years of adherence to maintenance therapies. And then in the US, unlike, I don't think you have the problem so much in Europe, but in the US, we've had only one manufacturer, and we've had, intermittent over the last 10 years, significant shortages. So that's some of the things that confront us with BCG in and of itself.
Super. Thank you so much. So, the next chapter is we're going to be talking about the combination of immunotherapy and BCG in high risk NMIBC patients. So, I'm going to be asking you, Maria, first. What is actually the rationale for combining immune checkpoint inhibitors or immunotherapies with BCG?
Well, there is some data out, preclinical and clinical data. Um, the BCG-induced immune resistance often involves an upregulation of PD-1 and PD-L1, firstly. And the PD-L1 expression tends to increase in BCG-resistant tumors, and this has been shown in some publications. And thus, we think that this would provide a potential target for the well-known checkpoint blockade, which is working in bladder cancer and has been approved in different clinical scenarios in bladder cancer. Further on, there are the preclinical studies and indicating better anti-tumor responses with combinations with BCG. Further on, there are phase 1 and 2 clinical trials indicating effectiveness of PD-1, PD-L1 inhibitors in high-risk NMIBC. And finally, there is FDA-approved pembrolizumab for the BCG-unresponsive high-risk non-muscle-invasive bladder cancer with carcinoma in situ, with or with papillary tumors, and who are ineligible for or have elected not to undergo cystectomy. So this is a broad range of rationale for the combination of immunotherapy with checkpoint inhibitors and BCG in this high-risk NMIBC population.
Super. That's really exciting. Thank you so much. And we have also had a number of clinical trials reading out recently. So the Alban, Potomac, Crest clinical trials, which we are going to talk through their data. And we are also still awaiting data from the Keynote 676 trial from cohort B specifically. So first of all, I wanted to just quickly introduce one of the first clinical trials, the Alban, and this is the study design. So it recruited BCG naive patients with high-risk NMIBC, and patients were then randomized either to receive standard of care BCG with the 6 weeks induction and 1-year maintenance phase, or the experimental arm where BCG in the same regimen was combined with 1 year of atezolizumab, which is a PD-L1 checkpoint inhibitor. The primary endpoint of the study was event-free survival with a number of key secondary endpoints. The trial was reported at the ESMO Congress at 2025, and unfortunately the results were negative. In terms of event-free survival, there was no difference between the two groups. In terms of adverse events, of course, if you are adding on an extra drug, there are going to be additional side effects as well. So we have seen these immune-mediated side effects occurring in the combination arm. Maria, would you like to walk us through the Potomac study, please?
Yeah, pleasure. So Potomac is a global multi-center open-label randomized phase 3 trial. And we included BCG-naive patients, just as in the Alban trial. They had high-risk tumors defined as T1, high-grade, grade 3, carcinoma in situ, or multiple and recurrent and large tumors of 3 centimeters and above. 1,018 patients were randomized into 3 treatment arms that included durvalumab, IV treatment for 1 year, plus BCG induction and maintenance for 2 years. Second arm, durvalumab plus BCG induction only, and the control arm was BCG induction and maintenance for 2 years. It was stratified by high-risk papillary disease and carcinoma in situ. The first endpoint was DFS of durvalumab plus BCG induction and maintenance versus BCG induction and maintenance control arm. There were, of course, several secondary endpoints, including DFS at 24 months, for example, and or overall survival. So Potomac met its primary endpoint. Disease-free survival showed to be superior with the addition of durvalumab for 1 year plus BCG induction and maintenance versus the control arm. The hazard ratio was 0.68 and the p-value 0.0154. We had a median follow-up of 60.7 months and a 24% DFS maturity. So a clearly positive trial. As for the subgroups, they were pretty much consistent over the whole range, consistent with the general DFS result. There was a little outlier with carcinoma in situ with a hazard ratio of 1, but a very broad confidence interval with relatively low numbers in that group. Um, Otherwise, I would like to mention over survival. Um, this was a secondary endpoint, and this was not statistically significant, but it was not powered for our survival. The hazard ratio was zero point 0.8, so I think an interesting trend. Um, the maturity over survival 14% only. Um, Not unexpectedly, we see more side effects with the addition of a checkpoint inhibitor. So coming to the side effects, we saw adverse events leading to the discontinuation of the study treatment and possibly related to durvalumab in 16% of patients, and possibly related to BCG, 16% in both groups. The investigational durvalumab plus BCG induction maintenance and also in BCG induction and maintenance control. So the addition of durvalumab did not increase the stopping discontinuation of BCG, for example. What we also saw was a relatively low grade of immune-related adverse events, grade 3 or 4 in 8% with the addition of durvalumab, and only 0.3% with the control on BCG induction and maintenance. The main side effects were coming from BCG with dysuria, hematuria, dysuria, etc. But of course, there were the additional immune-related side effects, which were well manageable, but mainly hypothyroidism, fatigue, a little diarrhea, or rash. I think this is the summary or bottom line of the results. Thank you.
Thank you so much, Maria. These are absolutely fantastic results. Neil, could you please go ahead and present us the CREST study and the results?
Yeah, very, very similar to Potomac. These were BCG naive, high risk NMIBC patients, the T1s, high grade TA, CIS, and no prior PD blocker exposure. Also over 1,000 patients, 3 cohorts, virtually identical design to Potomac. Cohort A was really the primary cohort to be compared to cohort C. Cohort A being the 2 years of sasanlimab given subcutaneously in conjunction with induction and maintenance for 2 years, similar to Potomac. Only difference in durvalumab, Potomac, it was the durvalumab was intravenous and was given for a year, but induction maintenance BCG for 2 years. And then there was this B arm or the middle arm where it was induction only and the sasanlimab for 2 years, and then the control being induction maintenance only. The primary endpoint was event-free survival as opposed to disease-free survival. They're almost identical. The acronym is different, but they're pretty similar for practical points of view. And then remarkably, the hazard ratio is exactly the same as Potomac, a 0.68 improvement in event-free survival. An absolute difference at after just really 3 years of nearly 6%. So I think that, and when you look at the subplot, the forest groups, much like in Potomac, some of the confidence intervals are broader, some are more narrow, but virtually every one of the subgroups, age, race, by and large, gender, disease categorization, really all favoring the combination group. Similar to Potomac and durvalumab, sasanlimab, the number of events for OS were very, very small in the intent to treat population. I think the key thing is there were no grade 5 events in arm A, the arm that you had sasanlimab in comparison to the induction maintenance. And ultimately, what we see very similar to Potomac, there are some differences in the actual percentages and some of the differences in the immune-related adverse events. But I think the take home bottom line is that in Crest, much like Potomac, we didn't see anything that we were not used to seeing with checkpoint inhibitor therapies. Our medical oncology colleagues are extremely comfortable with this because there's like 20 plus indications in various solid tumors. I think this is going to be something for the uro-oncologists to get their arms around.
Super, thank you so much. And again, that hazard ratio is absolutely amazing. Just to kind of remind everybody, as I said previously, the Keynote 676 clinical trial is still ongoing with, again, a very similar clinical trial design with a combination of pembrolizumab plus BCG, either with a full maintenance or with a reduced maintenance versus BCG monotherapy. So hopefully we will be able to see the data very soon. Now, just to summarize and put it all into context, so Alban, which was the combination of atezolizumab and BCG, showed no improvement in terms of high-grade recurrence-free survival or overall survival versus BCG. So this trial has not met its primary endpoint. The Potomac, which was the combination of durvalumab plus BCG induction and maintenance, met its primary endpoint, and the combination treatment has significantly improved disease-free survival versus BCG alone, with, as previously mentioned, the hazard ratio of 0.68. Crest, sasanlimab, and BCG, again, the combination treatment has significantly improved event-free survival versus BCG alone, while the induction-only arm was actually negative and no overall survival benefit was seen to this date. In terms of safety, obviously the combination strategies does show increased immune-related adverse events, but these were generally very well manageable and no new unexpected safety signals were seen. And so overall, the results are heterogeneous. So not all immunotherapy plus BCG combinations do add benefit. And so we do need to think about what agent we are going to be combining with BCG. And of course, the BCG maintenance strategy is extremely important. So finally, I would like to move on and explore the actual impact of these latest updates and all of the results on our future clinical practice. So what are the key differences between all of these clinical trials? Maria and Neil, would you like to comment on these, please?
Well, Bernadette, I'm not sure if I can add substantially to what you summarized now, but and also Neil summarized the differences. I think there are not so many differences. There are more factors in common, but differences are, of course, the length of the length of treatment with the PD-1, PD-L1 inhibitor, with durvalumab IV treatment for 1 year and sasanlimab subcutaneous treatment for 2 years. BCG induction and maintenance was for 2 years in both studies in the Crest and Potomac. So this would be the major differences. Otherwise, um, I think there are more similarities than differences between the trials. Yeah, maybe another note from Anil's side, but I'm not sure if I can add a lot here.
I agree with everything that Maria said. You know, some may say, well, there's a difference between whether it's a direct blocker or a ligand blocker, and that's a nuance of the MOA. You know, the length of BCG. BCG is a good drug. It's not ideal. It's not perfect as we described. And I think ultimately we'll have some further discussion on, well, why add an IO? Why add a checkpoint inhibitor?
And do you think that the differences between IV and subcut will make a substantial difference as to the usage and the uptake of the drugs?
You know, it's interesting. I think that some of the implication there, I don't think it will be throughput. How much chair time do you have? Can you get folks in and out of the clinic quicker with a sub-Q versus an intravenous? I think there's some advantages there. I don't know that we have any data to suggest that that's less adverse event beneficial or that there's necessarily anything clinically more beneficial about it. I think it's more of a practical issue.
Super, thank you so much. So having talked through all of the data, what do you think, Maria? What does the patient look like who could actually benefit from the combination therapy of immunotherapy plus BCG? Is there an ideal patient?
Well, I don't think that there is the ideal patient, but it depends on the patients and the patient's goals and uh, the, 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 the patient's willingness of taking maybe more treatment and more potential side effects with the benefit of a reduction of his risk of recurrence and progression, and with a higher likelihood to keep the bladder at the end of the day. And I think this is the major point, because otherwise we have the patient characteristics that were defined in the trials, like high risk or even very high risk NMIBC, um, according to the definition in the trials, with differences in the amount of carcinoma in situ or papillary only, etc. But I think we don't have that much information out of the subgroups to decide for the one or the other. I think both combinations, cesanlimab plus BCG and durvalumab plus BCG, were efficacious in broadly all subgroups. Yeah.
Thank you. And Neil, obviously, non-muscle invasive bladder cancer, also including high-risk non-muscle invasive bladder cancer, was traditionally a urologist only disease, and so we didn't really, had to reach out to the broader multidisciplinary team in order to deliver treatment to these patients. Now, obviously, with the combination, we are going to have to include, medical oncologists as well into the decision making. So what do you think? How will this change the management of these patients?
Yeah, it's a really important question. And there's a lot of variation depending upon where you practice, what your relationship is with your medical oncologist. It should be very evolved, hopefully, by now. GU oncology involves systemic therapy, localized therapy, bladder clearly now coming into its own. If you're a uro-oncologist and you're uncomfortable with managing PD blocker therapy, and you're not comfortable with the immune-related adverse events, although they're only approximately 10 to 12% of patients with the grade threes, then you absolutely should be very hand in glove working with your medical oncology team. But one of the challenges is we have a person power shortage across the world, med oncs, uro oncs, and so, as long as someone who's giving the therapy is skilled and well educated, and it's about patients having choice. So, yes, I believe in multidisciplinary care. I always have, regardless of the tumor type, certainly no less so with bladder cancer. But then, very importantly, another acronym group of letters is, SDM, or shared decision making. And I'm a believer that we no longer can be paternalistic and say, well, I'm going to tell you this is only what you can have. Now, let's keep in mind that neither the CREST or the Potomac data has been approved by any regulatory bodies. We're all, fingers crossed, hoping we see that approval in 2026. But assuming that it does get approved, I think the question you asked Maria is a really good one. It's not going to be for everybody, but at least having that shared decision making conversation. I've got multifocal CIS. I have a really good performance status, or I have T1 disease and I've been re resected and still T1. It's not in the muscle. What can I do? Or I have an extensive high grade papillary disease. Is I want my first shot to be maybe my best shot. So is it just intravesical therapy with BCG? Is there, I'm speaking as if I were a patient. Is there something else I could take? Yes, I have to recognize that there's a risk tolerability trade-off. And as long as the patient and the family really understands it, it's ultimately their decision.
Thank you so much. And just to wrap up, I would like to hear from each of you your final thoughts and key takeaways with regard to the combination therapy and using immunotherapies in this very much evolving landscape of non-muscle invasive bladder cancer. Maria.
Well, thank you for letting me start off. I think we have made a huge achievement after more than 30 years of BCG only therapy with all the challenges and compliance problems and side effects and risk of recurrence progression and losing the bladder at the end of the day. We have two trials that are positive that showed with the addition of checkpoint blockade that we can improve the results of BCG induction and maintenance therapy. So I think this is a huge achievement, and I'm really happy to can share the data and hopefully can inform the patient in the very near future of an option, a new option, and potentially improved therapy for their high risk NMIBC.
Neil, what's your takeaway?
Oh, I totally echo what Maria just said. Look, if we can cut down on progression and cut down on the need for cystectomy, cut down on the need for additional therapies or clinical trials so that patients can maintain their bladders and remain event-free, disease-free, this is what our goal is. And of course, we have to do it in a way that's thoughtful and we balance any additional adverse event concerns. I'm very proud to have been part of Potomac with Maria, proud to have been part of CREST. We're a large volume trial site for the 676 study. So this is how we do these trials to change clinical care. And I'm very hopeful that the agencies all throughout the world will see that as well, so patients have more options.
Thank you so much. And I absolutely share your thoughts, the both of you, and totally agree. And I'm just extremely grateful to have been born in this era where bladder cancer has got so many different treatment options, both in the local setting in NMIBC, but also in the metastatic setting. So just really excited about what the future holds for these patients. And finally, Maria and Neil, thank you for this excellent discussion. I really enjoyed our time together. And thank you for our audience as well for participating in this activity. Please continue to answer all the questions that follow from here on and complete the evaluation.